Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it is my great pleasure to have Dr. Maria Korber into our session for a quick interview on her latest publication, which is titled Performance of Transcatheter Direct Annuloplasty in Patients with Atrial and Non-Atrial Functional Tricuspid Regurgitation. Dr. Korber, thank you so much for joining us today.
You're very welcome. I'm happy to be here.
Thank you. Could you please begin by telling us how you define atrial functional tricuspid regurgitation?
Yeah, sure. I mean, of course, functional TR is the predominant etiology of TR overall, and functional atrial TR is basically a sub-entity that is discriminated from ventricular TR, mainly by characteristics like leaflet tethering, restricted leaflet movement, and also significant RV enlargement in patients with ventricular TR. So there is no unified definition of AFTR in the literature, actually, but Schlotter and colleagues recently were able to provide a definition of AFTR that was associated with prognostic relevance in both conservatively treated patients with TR and also in patients undergoing edge-to-edge repair for TR. And so we actually applied this definition in our study as well, and it uses very easily accessible echo parameters. So accordingly, AFTR was identified then when patients had a tricuspid valve tenting height that was below 10 millimeters, an RV mid-ventricular diameter of less than 38 millimeters, and a left ventricular ejection fraction that was preserved, basically. And if patients did not meet this criteria, then they were identified as having non-atrial FTR.
Perfect. Thank you so much for your response. So your study found that AFTR patients had significantly reduced tricuspid regurgitation grades and better outcomes after TTVA compared to NAFTR. Could you please elaborate on the key findings and the implications on clinical practice?
Yeah, right. So the AFTR phenotype indeed was a very strong predictor of the patients having TR equal or less than grade 2 at discharge and also at 30-day follow-up. And even after adjusting this for TR grade at baseline. And also AFTR patients indeed had a better survival at 1 year, even after adjusting for the presence of a higher residual grade of TR. And what was also interesting was that CT data and also echo data showed us that the baseline right heart dimensions of patients that had ventricular TR, so non-AFTR patients, were significantly larger. So maybe these findings suggest that AFTR patients actually represent the collective of patients maybe at an earlier in an earlier disease stage than ventricular TR patients. So their outcomes following an annuloplasty were indeed better and more promising, and this might underline the importance of an earlier treatment strategy to optimize the outcomes in patients undergoing tricuspid annuloplasties. So I think distinguishing between atrial and non-atrial FTR can quite easily be integrated in our clinical practice and might be a novel and valuable predictor of better outcomes in our patients that are treated with annuloplasty.
Thank you. That's great to hear, and it's great for patient care in the future. Moving forward, what additional research do you think is needed to further refine management of TR, particularly in patients with different phenotypes like AFTR, like you mentioned?
That's a very interesting question. Yeah, I think, of course, the appropriate timing of intervention in relation to clinical status, also severity of TR and right ventricular function is always of great interest, because I think now we have plenty of data suggesting that an earlier treatment strategy, like before there is intensive right heart remodeling or even impairment of RV function, might be associated with better outcomes. So I think all research going into this direction in the future will be very interesting. Furthermore, maybe we do not only need to understand predictors of good outcomes, but also maybe clinical and echo parameters that might indicate futility in the future of our patients. And of course, now of great interest also with the growing device choices we have for TR treatment is patient selection and also in different phenotypes. So I think it would be of great interest also to better understand the benefits or maybe superiority, inferiority of different devices like edge-to-edge repair versus annuloplasty versus even replacement in different phenotypes. So AFTR versus non-FTR. So I think all of these points might be of great interest for future research projects in TR.
Absolutely. That's so wonderful to hear. Thank you, Dr. Korber, for joining us today, and congratulations on your work.
Thank you so much.